Well, Indian College of Anaesthesiologists, welcome you to our Wednesday evening webinar of the college. And today, we'll be discussing certain aspects of mechanical ventilation, which I am sure you have heard sometime in the past. But there is some changes which are being discussed today, and kindly listen to the webinar. And probably as a continuation of the present day webinars on the mechanical ventilation, well, the same moderator will be introducing something more on mechanical ventilation, how to control the mechanical ventilation electronically through imaging device. That is going to be there in the next one. So today's webinar on mechanical ventilation in the ICU as well as in a chronically respiratory disabled patients we will discuss today, and all the discussions are from Amrita Hospital, or say Amrita Institute of Medical Science, Faridabad, New Delhi, and all are from the Department of Anaesthesiology of Amrita Institute, Faridabad, which is controlled and headed by Dr. Mukul Kapoor. Mukul Kapoor, you know very well, is the editor of our yearbook, as well as he's one of the finest scientific writers in anesthesia, as well as a well-known scientific authority on anesthesia matters. And he was with the army for some years, and later he's in the civil side, and he is head in the Department of Anesthesia at Amrita Hospital. Since I don't know much about all the people who are joining today, I don't know them in person, probably I may be able to know them in person. And I request Dr. Mukul Kapoor to introduce each one before they start talking on the subject allotted to them. And here we are, and I request Mukul Kapoor to take on and start the webinar.
Thank you, Dr. Radhakrishnan. It's a pleasure to be here again. And thank you for the kind words you've spoken for all of us and for me in particular. And I would like to say that we are talking about mechanical ventilation because mechanical ventilation has been changing over the years. It has changed dramatically over the years because we have been all looking towards improving patient outcomes. That every day that passes, there are some new developments taking place in mechanical ventilation. And because of these new developments, there is a need to continuously update ourselves on mechanical ventilation. Even a subject like ARDS has got multiple updates coming up regularly. See, the international societies of critical care medicine and are regularly taking out various updates, and almost it is something like the CPR guidelines, which are regularly updated by the American Heart Association. Similarly, the guidelines of ventilation for ARDS are also needing regular updates. And to speak on mechanical ventilation in ARDS, I have Dr. Ripenmeet Salhotra. Ripenmeet Salhotra is a senior consultant in critical care medicine in Amrita Hospital, Faridabad. Amrita Hospital, Faridabad, as Sir just introduced us, is also a medical college, and we are running different teaching programs in our college. Ripin, before coming into our fold in Amrita Medical College and Amrita Hospital, he was in the Fortis Hospital at Faridabad itself. He had earlier also worked in Tata Memorial Hospital in Mumbai. Ripin has been actually very prolific in his writing, and he has published a lot of original articles. Apart from original articles, the great thing about this young man is that he has also written 8 chapters in critical care books. For his age, and I think for his number of years in critical care medicine, that's a great achievement. Over to you, Ripin. Please talk about mechanical ventilation in ARDS.
Thank you, sir, for the wonderful introduction. And first of all, I would like to thank Dr. Mukul Kapoor, sir, for giving me this opportunity at this esteemed stage to talk. So I'll be talking about mechanical ventilation in ARDS. I know you have heard about this topic before also on this platform, I will be talking about some newer advances, some newer practical approaches which have been recently described in mechanical ventilation of a ARDS patient. And I also will be touching about the recent European Society of Intensive Care Medicine guidelines on ARDS, mechanical ventilation in ARDS, which has been recently published last year. So the agenda of my talk will mainly focus on these 4 points. First is setting optimal PEEP. Second is the various recruitment maneuvers and their. The third is a bit about driving pressure in a passive patient and also in a patient who is on assisted mechanical ventilation. That is, he's also breathing spontaneously. And lastly, about the newest concept which has been introduced just a few years back, that is mechanical power and how it affects the mechanical ventilation in a patient of ARDS. So, I would like to start with the lung protective ventilation, which has been described almost 20 to 30 years back. Uh, Initially, when ARDS was first described in 1960s, the patient used to be ventilated with high tidal volumes and high pressures. And at that time, the mortality in ARDS patients used to be around 70%. However, since the lung protective ventilation has been introduced, the mortality has decreased considerably. And currently, the recent trials show that the mortality in ARDS patients is around only 40%. So, what is lung protective ventilation? There are three very important components of lung protective ventilation. One is to ventilate the patient with low tidal volumes, that is the tidal volume of 6 ml per kg or less of predicted body weight or ideal body weight, which is based upon the height of the patient. The second is to keep the plateau pressure or the maximum pressure which a patient reaches during the tidal ventilation to less than 30 centimeter of water. And the third is to set a optimal PEEP. Besides this, there are other components which have proven to improve the survival of a patient of ARDS, which includes prone ventilation to keep the driving pressure less than 15. And I will also touch about mechanical power and recruitment maneuvers. So, coming to setting an optimal PEEP. So, what is an optimal PEEP? So, optimal PEEP is a PEEP which maintains recruitment in a patient of ARDS, which keeps the patient's lungs open, which are collapsed. These are usually the dorsal parts of the lungs. So an optimal PEEP keeps the recruits the lung and maintains the recruitments. It decreases the strain and it also prevents atelectauma. What is atelectauma? Which is the repeated opening and closing of the alveoli during tidal ventilation. However, PEEP by itself, if it is excessive and unnecessary, can cause barotrauma, which we see the pneumomediastinum or pneumothorax. It can affect the RA-RV pressures. It can cause RA-RV overload and subsequently cause hypotension, which will lead to excessive fluid infusions and ultimately fluid overload and difficult weaning in this pain. So, how to find the optimal PEEP? So, finding optimal PEEP remains the holy grail of critical care, and there is no perfect method to define what is the optimal PEEP for your particular patient. So, I will talk about a few methods which have been recently described for finding the optimal PEEP. So, coming to my first slide, this slide shows the PEEP FiO2 table, which has been described 20 years back by the ARDS net trial investigators. This table advises you to set the PEEP based on the FiO2 required by the patient to maintain a saturation of 88 to 95%. So, for example, if your FiO2 is 0.8, you should set a PEEP of 14. The problem with this table is that this is this table was empirically constructed, and there is no evidence base and physiological base for setting the PEEP based on oxygenation. Also, this table forces one to decrease the PEEP on improvement in oxygenation, and this ultimately leads to premature losing the benefit of PEEP. So I will go on to the second method. The second method is basing the PEEP on the best compliance. So how the best compliance is found and the PEEP is set. So I will show you an example of this ARDS patient. Uh, this patient was ventilated on volume control mode with a tidal volume of 420 ml. The PEEP was initially set at 6 centimeter of water, which was increased by 2 centimeter of water every 3 to 5 minutes. And what we have to look, we looked at the plateau pressure. So initially the plateau pressure was 30, it remains 30 when the PEEP was increased to 8, and when the PEEP was increased to 10, the plateau pressure decreased to 28. What does this mean? That the compliance of the lung has improved. When it was increased to 12, it remains 28. When the PEEP was increased to 14, the plateau pressure increased. So this means that the compliance has decreased. So the best compliance was at the PEEP of 12. So the PEEP was set as 12. So this is the incremental PEEP method. Similarly, incremental PEEP method can also be tried in a patient on pressure control mode, in which the pressure control, which is 18, will remain constant, and by increasing the PEEP, we will look at the tidal volume. If the tidal volume increases by an increase in PEEP, that means that the compliance is improving, and thus we can find the optimal PEEP for this patient, which is 14. Similarly, this can be done, this trial method can also be done in a decremental fashion, in which we start with a higher PEEP and then we decrease the PEEP by 2 centimeter of water at every step, every 3 to 5 minutes, and we find a PEEP which gives us the best compliance. So there are several trials which has been done in last 10 to 15 years, which compared high with low PEEPs. So these are the list of the 5 trials. The most important one was alveoli trial, Love's trial, and Express trial. So in all these trials, as you can see, there was no difference in mortality in high versus low PEEP. The P value was not significant. However, in a subsequent meta-analysis which was published recently, it was shown that high PEEP might be of benefit in very severe ARDS patients, and this PEEP should not be combined with a prolonged recruitment maneuver, and this might lead to some decrease in mortality and improvement in survival. So based on this evidence, the ESICM guidelines, which was released recently in 2023, suggests that they do not have adequate evidence to recommend high or lower PEEP in a patient with ARDS. However, they state that in a patient with severe ARDS, a recruitability test should be tried, and if the lungs of the patients are recruitable, then a higher PEEP should be applied in those patients. So for all patients, we don't have to apply high PEEP, we can apply low PEEP, but in very severe patients, if the patient's lungs are recruitable, we can go for higher PEEP. So what does they mean by recruitability, and how to check whether the lungs are recruitable or not? So I will show you the figures from a very seminal study by Dr. Luciano Gattinoni. In this study, they applied PEEP at various levels to a mechanically ventilated patient, and they did CT scan of the lung at various levels of PEEP. So in the above picture, these two above CT scan is of a patient who has a non-recruitable lung. Not recruitable, non-recruitable lung. So you can see on the left is a CT scan at 5 centimeter of water pressure. On the right is a CT scan at 45 centimeter of water pressure. You can see the amount of lung which is getting inflated. It almost same in these two pictures. So the PEEP has caused no benefit to the patient. But what else the PEEP has caused? You can see the heart in this picture. On the left, the heart, and on the right, the heart. You compare. The heart is completely compressed with these high pressures. This was because the lungs were hyperinflated, they exerted the pressure on heart and it got compressed. So what will this lead to? This will lead to decrease in the preload and hypotension with no benefit of PEEP. And in such patients, low PEEP should be applied. As compared to this, in the lower two CT scans, this is the CT scan of a patient who has a recruitable lung. As you can see, at 5 centimeter of water, only a small portion of lung is inflated. However, at 45 centimeter of water, a large portion of lung is getting inflated. Plus, there is no difference in the heart size in the two figures. So, this lower patient has a recruitable lung and a higher PEEP should be applied to this patient. But this was a study which was done in a CT scan, and this was an investigational study, and the CT scan cannot be done for every patient of ARDS, and this is not possible to take cuts at low PEEP, at high PEEP, and at various levels. So the CT scan is the gold standard of testing whether the patient has a recruitable lung or not, but it is not practically possible. So what are the other methods by which we can check recruitability? And I will talk about those methods. So the first and foremost and the simplest method is to apply the PEEP based on the severity of ARDS. Severity is based on the PF ratio, that is the PaO2 by FiO2 ratio. If the PF ratio at 5 centimeters PEEP is less than 100, that means severe ARDS according to the Berlin definition of ARDS, then there is a 70% chance that these patients will have a recruitable lung and high PEEP can be tried in these patients. This has been proven by this study. Coming to the second method, which is based on the morphology of the lung. You see 5 imaging of 5 different patients in this figure. The images A, the image C, these are 2 CT scans, and the image E, which shows a X-ray. This shows almost complete opacification of the lungs, and this pattern is described as non-focal or diffuse ARDS. However, the image B and image D shows only dorsal opacification, and this type of ARDS is known as focal ARDS. So you can divide your patients into having focal or diffuse ARDS or focal and non-focal ARDS. And high PEEP should be applied to patients having non-focal ARDS, and low PEEP should be applied to patients having focal ARDS. And this has been proven in the live study which was recently published, which showed that if high PEEP is applied to focal ARDS and low PEEP is applied to diffuse ARDS, that is vice versa of what we recommended, then the mortality increases several fold. The hazard ratio increases almost twice. So coming to third method, which is dividing the ARDS patient on a base phenotypes, and one of the most common method is to divide them into hyperinflammatory and hypoinflammatory phenotypes. If the inflammatory markers, for example, the most commonly used marker is IL-6, if it is high above a certain threshold, then we call that the patient is having hyperinflammatory phenotype of ARDS. And vice versa is hypoinflammatory type. And studies have shown that the survival is lower, considerably lower in hyperinflammatory phenotypes. And it has also been shown that the mortality is lower when high PEEP is used in hyperinflammatory phenotype. So if you get to know what is the phenotype of your ARDS patient, and if it is hyperinflammatory, go for higher PEEP, or at least try higher PEEP. The fourth method, which is lung ultrasound, which is commonly done at the bedside by the intensivist who is looking after a ARDS patient. The lungs of a ARDS patient can be scored based on these, as shown in this figure, from 0 to 3. The 0 is normal aeration pattern. We see A lines throughout. The score 1 and 2 is some loss of aeration. We will see B lines in score 1 and 2. And score 3 means complete loss of aeration. We will see C pattern or consolidation. That is complete one. So you perform this maneuver at you perform this lung ultrasound at low PEEP and then you repeat it at high PEEP. If there is a significant change in the score of the patient, that is from 3 to 2 or from 2 to 1 or 1 to 0, then it means that the patient has a recruitable lung and higher PEEP can be applied in these patients. So we have seen some methods by which we can check the recruitability by imaging and by the lung phenotypes. Now coming to what can be done at the bedside without imaging. So there are certain lung mechanics which have been recently, certain manuals which check the lung mechanics which have been recently described, which can help us find whether the patient has a recruitable lung or not. So these are PV curve, stress index, transpulmonary pressure, which needs an esophageal pressure monitoring device, and the RI ratio, which is the recruitment to inflation ratio. So coming to the first method, which is the PV curve. For this, we need to construct a graph which is based on pressure on the x-axis and volume on the y-axis by giving very low flows to the patient. This for performing this maneuver, some ventilators, for example, this screenshot is from a Hamilton G2 ventilator, which has a special tool called PV tool, which can construct a PV curve automatically at very low flows. So if you have this ventilator, you can construct a PV curve, and this point, which is when the slope of the PV curve changes initially, is known as the lower inflection point, which is also denotes the opening pressure of the lung, and PEEP should be set above the lower inflection point. For example, in this patient, this comes to around 15 and PEEP should be set above 15. The second method, which is also based on the PV curve, is the shape of the PV curve. If the shape is concave or convex, as seen in this figure, that means the lung is showing a hysteresis behavior. What is a hysteresis behavior? That during inflation at the same pressure, the volume is lower. However, during deflation, the volume is higher at the same pressure. That means the lung was recruited and it remains recruited during the maneuver. So this means that the patient has a recruitable lung. If the shape is convex, you can go for higher PEEP. If the shape is not so convex as seen in this second figure, then we can consider the patient is having a non-recruitable lung and we can go for lower PEEP. The third is you can calculate the hysteresis ratio, which is nothing but the ratio of this maximum distance between the two inspiratory and expiratory curve on a PV loop to the total volume. If this distance is more than 40% of the total volume, then we say that the patient is showing hysteresis and the lungs of the patients are recruitable. This has been validated against the gold standard, which is the CT scan in this study. So coming to the next method, which also uses the lung mechanics, is the stress index. The stress index is a dimensionless coefficient which can quantitatively describe the shape of the pressure time curve. And generally, it requires complex instrumentations and analytical software. However, some ventilators, including the servo I ventilators, which is a very popular ventilator, gives SI directly to every ventilated patient on every ventilated patient. So the pressure time scalar looks like this. So this is a normal pressure time scalar. The stress index is around 1.0, which is normal. 0.9 to 1.1 is normal. However, if the shape of the curve is convex, that means the stress index is less than 0.9, and at this point we need to increase the PEEP till the stress index is becomes more than 0.9, and if the shape of the curve is concave, then we need to decrease the PEEP or tidal volume. This means that the patient is getting hyperinflated with the PEEP. So what will you do if your ventilator doesn't give the stress index directly? You don't have servo I ventilator. Then you can freeze the screen of the ventilator while the patient is getting ventilated. You can take a scale and you can apply it over the pressure time scalar, and you can find whether it is convex or concave, which can give an estimated of stress index, and this has also been validated in a study. So coming to the next method, which is transpulmonary pressure. So what is transpulmonary pressure? Transpulmonary pressure is the actual distending pressure of the lung. It doesn't take into account the pressure which is required to inflate the chest wall. It is the pressure which is required to inflate the lung minus the required to inflate the chest wall. This method is particularly useful in patients who are morbidly obese, in which the pressure we apply to the patient will be required to inflate the lung, but also to inflate the heavy chest wall. So, what is the formula for transpulmonary pressure? It is the difference of alveolar pressure minus pleural pressure. Alveolar pressure is the pressure which we measure on the ventilator, the pressure time scalar, and the pleural pressure is obtained by inserting an esophageal pressure monitoring device into the esophagus. So, how the PEEP should be set based on the transpulmonary pressure? So, PEEP means the positive end expiratory pressure. At the end of expiration, what is the positive pressure in the lung of the patient? So, transpulmonary pressure should be positive at end expiration. If the transpulmonary pressure is negative, there will be atelectasis or collapse of the alveoli at the end of expiration. So, set the PEEP just above or at least equal to the transpulmonary pressure. This is the goal of setting the PEEP based on transpulmonary pressure technique. So I will give you an example of this ventilator screen. You can see that first one is the pressure time scalar, second is the flow scalar, the third is the esophageal pressure graph. So this is the esophageal pressure graph, and the fourth is the transpulmonary pressure graph. Transpulmonary pressure is nothing but airway pressure minus the esophageal pressure. So this is the inspiration and this is the expiration. As you can see, we have set the PEEP to 5, and at this PEEP, the end expiratory pressure is negative. This is below the baseline of 0. That is, the end expiratory transpulmonary pressure is negative. This will lead to collapse of alveoli. So what we need to do? We can see in this figure what the uh, intensivist is doing. He will increase the PEEP till the transpulmonary pressure becomes 0 or slightly positive, like 1 or 2. So he is increasing the PEEP from 5 to 15 to 14. Sorry, he has increased the PEEP to 14, and now the transpulmonary pressure is 0 at end expiration. So this will lead to improvement, prevention of atelectasis and improvement in oxygenation. So the transpulmonary pressure approach was tested in 2 trials. The first was a smaller trial, F.1 trial, and the second was F.2 trial. Though there was no difference in mortality, but the oxygenation was better in the transpulmonary pressure group. So if you have a esophageal pressure at your disposal in your ICU, you can try this transpulmonary pressure technique. So coming to the fourth and the last method based on lung mechanics, this method is known by the name of RI ratio, which is the recruitment to inflation ratio. This was proposed by Dr. Laurent Brochard and his group from Toronto, Canada. Uh, uh, this method test, see, whenever we apply PEEP to a patient, some amount of the pressure goes to the collapsed lung and it leads to opening of this lung, as shown in this yellow marker on the CT scan. And some of the pressure which of the PEEP, some of the part of the PEEP goes to the already inflated lung, and this causes hyperinflation. So with this maneuver, we try to find what is the ratio of volume which goes to recruitment to the ratio of volume which goes to inflation. And if the ratio is more than 0.5, that means the PEEP is causing more recruitment than hyperinflation, and higher PEEP should be applied in these patients. This maneuver can be done on any ventilator at the bedside. And for this, we require just 2 minutes, and we require to do a very simple maneuver, which includes decreasing the PEEP suddenly from a high level, for example, 15 to 5. From 15 to 5, a difference of 10. So this sudden drop in PEEP will lead to release of the trapped volume, which is causing inflation or recruitment at the level of PEEP of 15. And this volume is measured by the ventilator after in the next breath. And if and with a very simple calculations, we can come to the RI ratio. You don't need to do these calculations by yourself. You can go to rtmaven.com, which is a site started by the publishers of this study, and you can enter the values, the different tidal volumes at the different plateau pressures at 2 PEEP, and this calculator will calculate the RI ratio. If the RI ratio is more than 0.5, you can go for higher PEEP, for example 13, 14, 15. And if the RI ratio is less than 0.5, that means the lung is not recruitable, and you can go for lower PEEP, less than 10. So this was about setting optimal PEEP. Now I will come to recruitment manure. So what is a recruitment manure? So recruitment manure is a trial of giving sustained high pressures above the safe or recommended pressure, that is the P plat of 30. We have to give a pressure above this for a sustained period of time. So it can be 40 centimeter of H2O for 40 centimeter of water for 40 seconds, or 35 centimeter of water for 35 seconds, or something like that. So these are recruitment manures. Most commonly it is given, it is very easy to give. Set a patient on pressure support CPAP mode, decrease the pressure support above PEEP to 0, and then increase the PEEP to 40, for example, for 40 seconds, and then go back to your usual mode. So by this you can give a recruitment manure. What is the advantage? It will open the collapsed alveoli, and this recruitment will then be maintained with a PEEP. So some authors have also described this recruitment manner in a stepwise manner, and in which way they stepwise increase the PEEP. For example, 40 centimeter of water for some 30 seconds, and then 50 centimeter water, then 60 centimeter of water, and then they give a decremental trial and go back to a optimal PEEP. So what studies have shown that you don't need a prolonged recruitment manure for optimal recruitment of the lung. Most the study here, which is quoted here, has shown that the maximum recruitment occurs in the first 25 to 30 seconds, and there is no significant recruitment after 30 seconds. So if you want to try recruitment manure, try it for 30 seconds and don't go above 40 centimeter of water. Why is that? Because in this recently published ART trial, which was published in JAMA, along with recruitment manure with standard of care ventilation in ARDS patient, and they found that the mortality increased if we apply prolonged and recruitment manures at very high pressure. These authors tried almost 60 centimeter of water, and almost 3 to 4 patients in the investigation arm had cardiac arrest during this manure. So based on this, the ESICM guidelines recommends against prolonged recruitment manures. However, short and safe recruitment manures, that is up to 30-35 centimeter of water for 30-35 seconds, can be tried in very severe ARDS or patients having refractory hypoxia. So we have learned about setting optimal PEEP and recruitment pressures. Now I will talk a bit about driving pressures. So what is driving pressure? Driving pressure is a pressure which is required to inflate the lung to provide the tidal volume to the lung. So by in a patient on controlled mechanical ventilation, it is given by the plateau pressure minus the PEEP. However, driving pressure can also be given by the formula tidal volume upon compliance of the respiratory system. That means, what is driving pressure? Driving pressure is tidal volume which is normalized to compliance. For example, the guidelines suggest that keep the tidal volume to 6 ml per kg, which is based upon the ideal body weight, not based upon what is the condition of the lung. In the above figure, there is very little inflatable lung which can accept the tidal volume. In this figure, there is a huge inflatable lung. Both the patients have ARDS. So if we give 6 ml per kg tidal volume to this patient, the driving pressure will be very high. If we give 6 ml per kg to this patient, the driving pressure will be low. So higher levels of driving pressure are independently associated with mortality regardless of the level of PEEP, tidal volume or plateau pressure. This has been beautifully explained by this study by Amato et al., which has been published in NEGM. They show that as the driving pressure increases above 15, the mortality increases exponentially. Also, this association of driving pressure with mortality is independent of plateau pressure and is independent of tidal volume and is independent of PEEP. For example, in this first figure, they show that the driving pressure is increasing, but the PEEP remains constant. However, the mortality keeps on increasing. In the second figure, they show in a group of these patients that the driving pressure remains constant. However, the plateau pressure is increasing by the increase in PEEP. But as the driving pressure is constant, the mortality remains constant. So driving pressure, this study shows is a more important parameter than tidal volume and PEEP and plateau pressure uh, uh, to decrease mortality. So this has also been shown in this experimental study by the authors of those of that trial. In both these experimental lung models, the tidal volume was within the safe limits, that is less than or equal to 6 ml per kg. However, the driving pressure was only was 18 in the first experimental lung model, and it was only 10 in the second. And after 48 hours, you can see the lung was how the lung was damaged in the first experiment, and it was not in the second experiment because of the low driving pressures. So how do you limit the driving pressure? So the first and foremost is to limit the tidal volume to 6 ml per kg and plateau pressure to less than 30. If you have met these two criteria, then you should calculate the driving pressure, which is nothing but the difference between plateau pressure and peak. If your driving pressure is more than 15, then you should try other methods to reduce the driving pressure. We include recruitment maneuvers, setting optimal PEEP, trying muscle paralysis, and trying proning of the patient, which will increase the recruitment and decrease the driving pressure. If the driving pressure is still more than 15, you can try to reduce the tidal volume below 6 ml per kg, 5 ml per kg, 4 ml per kg. What is the disadvantage with this approach is that your CO2 will go on rising, and you can try some other methods to decrease the CO2. For example, you can use a heated humidifier instead of the HME filter, which will reduce the dead space and decrease the CO2. Or you can increase the inspiratory pause, which leads to better mixing of gases and better clearance of carbon dioxide. If these are not useful, you can go for extracorporeal removal of carbon dioxide. So as soon as our patient of ARDS shows some improvement after controlled ventilation of 1 or 2 days, which is usually seen after 2 to 3 days, you should try giving a spontaneous respiration trial to the patient, and the paralysis should be stopped, and he should be given opportunity to breathe either with a SIMV mode or assist control mode or with pressure support mode. What is the advantage? This will prevent the diaphragmatic weakness and obviously decrease the sedation requirement and its side effect. However, there is a disadvantage of allowing spontaneous respiration, which the most important is ventilator-induced lung injury, also known as P-SILI, which is patient self-induced lung injury. Also, excessive patient efforts can lead to diaphragmatic injury in these patients. So, how to find the sweet spot, and how to find whether a patient who is breathing spontaneously is not damaging his lung and diaphragm. So, one obvious thing is if the patient is taking very deep breaths, is very tachypneic, obviously he is causing P-SILI and diaphragmatic injury, and he is not yet fit for spontaneous respiration, and you have to control the ventilation. However, in some patients it is not so obvious. For example, this was a patient with us who had ARDS, and on day 4, his FiO2 requirement decreased to 40%, and we put him on pressure support mode. So the pressure support above Peep was 6 in this patient. However, this is not the patient's real driving pressure for this ventilation. Why? Why is that? Because as you see in this equation of motion, the pressure applied for distending the lung is not just the pressure which we are providing through the ventilator, which is 6 centimeter of water. It is also the pressure which the patient is applying through his muscle as he is active and he is breathing. So we must account for both pressure exerted by the ventilator and the pressure exerted by the patient himself, which is known by PMUS. So how to calculate PMUS, and which will help us to calculate the driving pressure in this patient. So for this you need a esophageal pressure, which is a very costly and invasive device and is not available to most of us. So there are some other very simple techniques which have been described to calculate true plateau pressure and driving pressure in these patients. The first one is to give a inspiratory hold. As we can see in this video, the pressure is ventilated on pressure support mode, and a inspiratory hold is applied. As soon as the inspiratory hold is applied, the patient relaxes and stops exerting negative inspiratory pressure, and we get a true plateau pressure in this patient. So when we applied this to our patient, our true plateau pressure was around 22 and our driving pressure was 16. So another method is to give a expiratory pause and to measure the negative swing which the patient inhales during the tidal ventilation, which is also known by the pressure of occlusion or POCC, and which will help us to find the driving pressure in this patient. So what happens if the patient is having excessive effort or is having high driving pressure while he is breathing spontaneously on pressure support mode? The patient is recovering, he's on pressure support mode, and he's having high driving pressures or excessive effort. What you can do? So one is to increase the pressure support, which might lead to decrease in the negative swings exerted by the patients. If this is not helping, you can try increasing the Peep, try increasing the FiO2, which will increase the oxygenation and decrease the respiratory drive. Try producing some alkalosis by giving soda bicarb, or if these doesn't work, increasing the sedation or trying partial paralysis. So last but not the least, I will talk about mechanical power, which is a newer concept which has been very recently described. As we have seen that most of the guidelines recommend monitoring and controlling these parameters, which are the tidal volume, plateau pressure, or driving pressure in a patient who is ventilated for ARDS. However, the concept of mechanical power aims to quantify the contribution of other parameters like respiratory rate, the flow delivered to the patient, and the positive and expiratory pressure applied to ventilatory induced lung injury. To explain mechanical power, I will show you this equation, which is the equation of motion for a mechanically ventilated patient. The total pressure applied to the respiratory system is equal to the pressure which is applied to overcome the elastance, and the pressure required to overcome the resistance plus the positive end expiratory pressure. If we multiply all these three with tidal volume, we get the work of breathing during a single breath. And if we multiply this work with respiratory weight, we get the mechanical power delivered to the patient during 1 minute. So, and the concept of mechanical power was first explained to us by Dr. Gattinoni, and they give this complex equation to calculate mechanical power. You don't need to remember this equation, but you can see that this equation includes not only tidal volume and plateau pressures, but also respiratory rate, PEEP, and the resistance and flows, which are denoted by IE ratio and resistance of the respiratory system. So These are some of the simple equations which can be used at bedside, but I don't think it is necessary to calculate mechanical power for every patient. I will show you in next slide. So what studies have shown that the mechanical power, the higher the mechanical power, the higher is the ventilator induced lung injury and higher is the mortality. So one of our goals to ventilate a patient of ARDS is to reduce the mechanical power as low as possible. And what are the factors which affect the mechanical power? So tidal volume, if it is doubled, it increases the mechanical power fourfold. If respiratory rate is doubled, the mechanical power increases 1.4 times. And if PEEP is doubled, the mechanical power increases 2 times. However, if the sum of all these, if put into the formula, if it is same, the damage will be similar. So, how to use mechanical power at bedside, I will show you with this example. So, this was a patient of ARDS who was ventilated on assist control, volume control mode. He was sedated, not paralyzed. He was having high grade fever, 39.4 degrees centigrade. He was in the supine position, 30-degree head up. He was on volume control mode on a FiO2 of 0.9%. The flow was decelerating type, which goes like this, decelerating type of flow. The IE ratio was 1:2.5. Tidal volume was 7 ml per kg of predicted body weight. Respiratory rate was 30. Why so high respiratory rate? Because was having high PCO2 and acidosis on the ABG. So what things can be done in this patient which will reduce the mechanical power? So I will give you what we did. So we first of all we tried to reduce the patient's fever by giving him antipyretics and cold sponging, and it was reduced to 37 degree. Why? Because this will decrease the CO2 production, and we would be able to decrease the minute ventilation. Uh, Second, he was in supine position. We termed him prone, which will increase the recruitment and better ventilation. Third, he was just sedated initially and we paralyzed him with the infusion of atracurium. Fourth, we changed the flow waveform of the patient from decelerating to square, as the square waveform is better in mixing the gases and the elimination of carbon dioxide. We increased the IE ratio from 1:2.5 to 1:1.25, which also increase in elimination of helps in elimination of carbon dioxide. We reduced the tidal volume from 7 to 6 ml per kg, and we reduced the respiratory rate. So the minute ventilation was reduced from 14.7 to 10.5. Though the CO2 production was decreased by other manures, still the patient's CO2 rose from 45 to 60, and we were not bothered because permissive hypercapnia should be allowed in ARDS. The pH of 7.2 or PCO2 of 60 is not harmful, but a high mechanical power delivered to the patient is harmful. So we don't have a particular threshold for mechanical power, but with various maneuvers we can try to reduce the mechanical power delivered to a patient and thus reduce the mortality and ventilator induced lung injury. So this is my last slide. I will like to revise the take-home points. So lung protective ventilation, which includes ventilating the patient at a tidal volume of equal to or less than 6 ml per kg, and keeping the plateau pressure less than 30 centimeter of STO, have shown to decrease the mortality in ARDS and should be strictly followed while ventilating these patients. In mild ARDS patients, you can apply low PEEP. There is no need of higher PEEP in these patients. What is low PEEP? Anywhere between 5 to 10. In severe ARDS patient, high PEEP, which is between 12 to 18, can be applied and should be applied only if the lung is recruitable. Uh, After this, you should keep the driving pressure less than 14 to 15, even if your P plateau is less than 30. You should try to target the driving pressure of less than 14 to 15. You should also measure and reduce high spontaneous effort and driving pressure in recovering ARDS patients. And you should try to decrease mechanical power delivered to the patient. And there is no particular threshold or value for this mechanical power. So, thank you.
Thank you, Ripin. Thank you for a wonderful talk covering various new aspects about mechanical ventilation. And mechanical ventilation is changing dramatically ever since the concept of lung protective ventilation has started. And you have enumerated a wonderful, in a wonderful way, how to give optimal Peep and how to give recruitment, and thereafter the new concepts of driving pressure and also mechanical power. Everything is now moving towards this, and we are trying to protect the lung in a much better manner. And the most of these studies are coming from critical care, and most of the studies are coming from ARDS, though they have got their applications even in other places. But critical care is the place where all the pioneering work is happening, especially in patients who have suffering from ARDS. So thank you very much for very comprehensively covering this topic and giving all the recent data and the recent advances in how to do mechanical ventilation. Thank you, Ripon. So we now move on
Thank you,
and
sir.
to the second talk of the day. The second talk of the day is by Dr. Aayush Chawla. Dr. Aayush Chawla is also a consultant in critical care medicine in Amrita Hospital, Faridabad. And Dr. Aayush Chawla is an MD from BHU. Thereafter, he has done his IDCCM and IFCCM in critical care medicine. During his MD, he was a gold medalist. He received an award for excellence in outstanding contribution to critical care medicine during Critical Care 2018. He is a founder member of the Fluid Academy of India. He is the present treasurer of the ISCCM Faridabad branch, and he is the author and co-author of many book chapters again. Again, Dr. Aayush Chawla has got a lot of interest in various fields as concerned about the critical care medicine. And today he's talking about a relatively, again, a new topic, which we've always heard about negative pressure pulmonary edema under anesthesia conditions and during extubation. But this is a new concept, weaning-induced cardiac dysfunction and negative pressure pulmonary edema as a result of that. Over to you, Dr. Aayush.
Very special thanks to you, sir, for giving me this opportunity to present this topic. And after a very elaborative discussion by Dr. Ripan, now let's come down to a slightly easier topic to discuss, which is weaning-induced pulmonary dysfunction, weaning-induced cardiac dysfunction for that matter. So it's quite a frequent and treatable cause of weaning failure. And the diagnosis of weaning-induced pulmonary edema should be suspected whenever SPT trial fails and you've ruled out another cause of weaning failure. It particularly is found in some of the high-risk populations like patients who have an underlying left heart disease, in advanced COPD patients, as well as in patients who are morbidly obese. And the incidence reported in few studies, in the latter studies, in the past studies, was close to 10 to 30% of the total weaning trials being conducted in ICU. So how it all began and how it was diagnosed was, a lot of work has been done by Dr. Jean-Louis Taboul. Dr. Jean-Louis Taboul, when he was a resident in a hospital in France and was on rounds with his senior, Dr. Francis Lemar, suddenly a nurse came and asked him to see a patient who had developed a chest pain during the spontaneous breathing trial. He was basically a 65-year-old guy with no prior history of coronary arteries, and he was being mechanically ventilated for COPD exacerbation. EC performed during the process of weaning showed that there was ST elevation MI at the time of weaning. And so they confounded, they thought that there could be some deleterious cardiac pulmonary infection which have occurred in the process of weaning, and they have led to the patient having a STEMI. What they found was that when this patient was weaned from mechanical ventilation to spontaneous breathing, then there was significant elevation in pulmonary artery equilibrium pressure, which was merged with the type of a pulmonary artery catheter in place. Also, they found that at the time of weaning, you can find that the esophageal pressure because of negative pressure goes down significantly. But the difference between pulmonary artery pressure to the pleural pressure outside, that is the esophageal pressure, is still quite high. So hence, this significant elevation in pulmonary artery pressure has led to the development of cardiac pulmonary edema in the process of weaning, that is the negative pressure pulmonary edema. And they found that after using diuretic therapy, these patients showed a significant reduction in pulmonary artery pressure at the end of SPT and hence successful weaning. Ideally, there is no definitive value of POP, that is the pulmonary pressure above which cardiac pulmonary edema develops, but in most of the studies, a cutoff of 18 has been concluded. Baseline pulmonary artery pressure will never give you a reliable prediction of weaning-induced cardiac dysfunction. So what are the mechanism? What is the mechanism of this process? Whenever the patient is weaned from positive pressure ventilation to negative pressure ventilation, that is to spontaneous breathing trial, then there is reduction in the intersystemic pressure because it was initially positive. Now the patient is breathing spontaneously, so it will be negative. This will lead to a marked increase in the seismic venous return, causing increase in the LV preload. Also, there will be a slightly increased sympathetic activity because the patient is now under a stressful condition. He is trying to do exercise, where that is when he is being weaned. So there will be increase in the catecholamines, and these catecholamines will further increase the LV afterload, as well as the effects of hypoxia, hypercapnia, and increased work of breathing will all lead to increase in pulmonary vascular resistance. This increase in pulmonary vascular resistance, in turn, will cause increase in the right side pressures and RV dilatation. And because you know that there is a lot of bioventricular interdependence, this increase in RV pressures will further lead to a decrease in LV compliance. And all these things, that is a decrease in the venous pressure, venous return, causing increase in the LV preload, increase in the LV afterload, as well as a decrease in LV compliance, can result in increase in LV and diastolic pressures, and hence the development of cardiogenic pulmonary edema. So what they found was that in all the patients, when they subjected from mechanical ventilation to spontaneous breathing, there was a simultaneous increase in both the pulmonary artery pressures as well as the LV and diastolic volume index. And this is attributed to increase in preload, or to the increase in afterload, or decrease in LV contractility. But in some of the patients, you will find a marked decrease in pulmonary artery pressure as compared to LV and diastolic volume increase. And these are the patients, particularly those who have a underlying decreased LV compliance. And these are the patients who have a high chances of weaning-induced pulmonary edema when they subjected to weaning. Ideally, there is a curvilinear association of the LV and diastolic pressures to the volume. And this is a curvilinear probe, curvilinear graph. We can find that when there is a mild increase in the LV and diastolic volume, there will be a mild increase in pressure. But when the venous return goes on increasing to substantial levels, then you can then for the similar increase in the LV and diastolic volume, there will be marked increase in the LV pressures, and hence the development of cardiogenic pulmonary edema. So this phenomena occurs particularly when the patient develops congestive heart failure. This effect is particularly pronounced, is amplified in patients who have an underlying coronary artery disease in CHF as well as in COPD, where you will find a leftward shift in the LV and diastolic pressure curves. So basically, most all the studies found that it was probably the LV diastolic function which was the male culprit of the patients developing weaning-induced pulmonary edema as compared to the LV systolic dysfunction. So patient may have a normal ejection fraction, a patient may have a mildly reduced ejection fraction, but this is not the main cause of weaning-induced pulmonary edema. The main cause of weaning-induced pulmonary edema is the development of increased LV and diastolic pressures. So how do you predict and how you diagnose weaning-induced cardiac dysfunction? You can have invasive tools as well as non-invasive tools. The invasive tools were basically the use of pulmonary artery occlusion pressure, which requires putting up of a pulmonary artery catheter. You can measure the SpO2, which is again measured with the pulmonary artery catheter. It is a mixed venous oxygen saturation. And also you can measure extravascular water, which requires use of a transpulmonary thermodilution device. And now with the advent of echocardiography, we have a non-invasive tools to diagnose weaning-induced pulmonary edema. We can use certain biomarkers, cardiac biomarkers like BNPs and NT-proBNPs. Certain other modalities which I'll be discussing later are like hemoconcentration, as well as the use of passive leg raising test to diagnose and to predict weaning-induced cardiac dysfunction. So this was a quite old study which came in the American Journal of Respiratory Critical Care, where they found that when the patients were given when they were patients were weaned from mechanical ventilation to spontaneous breathing, then the patients who had succeeded the SBT trials, they had no reduction in SCO2. But the patients who failed SBT and they had shown to have marked increase in the pulmonary artery occlusion pressure, that is the development of weaning-induced pulmonary edema, they showed a quite significant reduction in SpO2 because of the combination of relative decrease in oxygen transport as well as increase in oxygen extraction by the end tissues. So what we assume is that whenever the patient is subjected to weaning, significant reduction in ScO2 is a marker of the patient developing cardiac pulmonary edema and weaning-induced pulmonary dysfunction, cardiac dysfunction. Use of echocardiography has increased quite a bit in the last decade or so in ICU, and it has also been used to diagnose weaning-induced pulmonary dysfunction. They found that at the end of spontaneous breathing trial, the combination of E by A ratio of more than 0.95 and E by E dash of more than 8.5 accurately predicted the patients who were predisposed to weaning-induced cardiac dysfunction and manifested in the form of increased pulmonary artery occlusion pressure. What they found is that E by A is ideally measured with the help of a pulse Doppler. Pulse Doppler applied at the mitral wall, and we measure the early and the late peak diastolic velocities. And E dash and A dash are ideally measured with the help of a tissue Doppler imaging of the mitral annulus, where you put the tissue Doppler probe at the level of mitral annulus and you measure the diastolic velocities. I just explained this in slight detail. So this is the mitral wall. You applied a pulse Doppler here, and you press the Doppler. This is the two peaks which you get. This is the early and this is the late peak of the diastolic velocity of the mitral valve. Similarly, the downward image is the tissue Doppler image, where you have applied the Doppler at the level of left at the lateral mitral annulus, and you have pressed the tissue Doppler. The downward peaks are early and the late peak diastolic velocities at the level of mitral annulus. So you measure two ratios, E by A and E by E dash. So E by A ratio of more than 0.95 along with a E by E dash ratio of more than 8.5 have successfully predicted weaning failure in the patients who have an underlying cardiac dysfunction. Okay, some of the patients also develop significant MR at the end of weaning induced when they have weaning induced pulmonary dysfunction. And the mechanism of MR is predominantly worsening of the functional MR because of increased LV afterload, which can occur because of the increased catecholamine self, which occurs during the process of weaning. They can be increasing the restrictive ischemic MR because of increased workup within, and also they may sometimes develop eccentric MR, which can occur because of the systolic entry motion of the mitral valve to the LVOT, when because of the increased sympathetic drive. So on the left side is the patient who has failed SVT due to weaning-induced pulmonary dysfunction. Here you can find that there is a quite increase in the functional MR component, and also you can see that there is quite significant elevation of the E and A, that is the peak diastolic velocities. So these patients who failed weaning when they were given vasodilators in the form of nitrates or maybe AC inhibitors, we found that they succeeded the SVT trial, and concomitantly the echo which was done showed that there was reduction in the component of functional MR. Also, there was a reduction in the E velocities as well as the A velocities at the end of weaning. The downward graph shows that the patient has developed some amount of eccentric MR. Here you can see the eccentric MR because of the systolic entry motion of the mitral valve as to the LVOT. And these patients failed weaning. Similarly, when these patients were given a trial of beta blockers, their weaning was successful, and there was a marked reduction in the eccentric MR jet, which you can see in the graph on the picture. So after echo, some other tools which have become quite popular are the use of cardiac biomarkers like BNPs and NT-proBNPs to diagnose weaning failure. SVT-induced changes in either of the plasma BNP or the NT-proBNP concentrations, but not the baseline values, will ideally predict weaning failure. BNP is quite a reliable marker because it has a shorter half-life as compared to NT-proBNP. The half-life of BNP is 20 minutes and that of NT-proBNP is slightly higher, 1 to 1.5 hours. And this study, which was again done by Dr. John Luther Boole, found that increase in BNP concentrations of more than 12% successfully predicted weaning-induced pulmonary edema with an average of a fair bit of sensitivity and fair bit of specificity also. But remember that you have to use a rise in BNP, not the single values of BNP. And also keep in mind that the BNP values can be elevated in patients of advanced age, elderly patients, sepsis patients, kidney dysfunction patients, even in the absence of LV dysfunction. So you have to use delta BNP and delta NT-BNP to diagnose weaning-induced failure. Higher cutoff can be used in renal failure because of decreased peptide clearance. This graph shows that delta BNP and delta NT-proBNP, they are quite specific and sensitive to diagnose weaning failure as compared to just using the NT-proBNP or just using the BNP values. A word about extravascular lung water to diagnose weaning failure. Although we do not use it routinely, but because it requires the use of a transpulmonary thermodilation device. So even at the end, like when you're weaning the patient, you will require to easily monitor them with the help of a femoral artery catheter and a central venous catheter at the time of weaning. And again, the study done by Dr. John Luther Boole found that increase in extravascular lung water of more than 14% was able to diagnose the patient with weaning-induced pulmonary edema with a fair sensitivity, but quite a high specificity. Hemoconcentration also occurs at the time when the patient experiences weaning failure because of weaning-induced cardiac dysfunction. This is because weaning failure pulmonary edema is a kind of hydrostatic pulmonary edema. There is shifting of the hypocotic fluid from the lumen of the pulmonary capillaries towards the interstitium and towards the alveoli. This results in hemoconcentration and will be increase in the plasma protein as well as the hemoglobin concentration. And this study found that an increase in the plasma protein concentration of more than 6% at the end of SVT and the HB concentration of more than 6.5 adequately predicted weaning-induced pulmonary edema with again a fair bit of sensitivity and specificity. The mechanism is that whenever the patient experiences some amount of hydrostatic pulmonary edema, the fluid sequestrates from the vascular compartment into the lungs and into the interstitium and causes a rise in the plasma protein concentration and the hemoglobin. So when you measure the hematocrit or when you measure the plasma protein concentration before the SVT and at the end of SVT, you will find an increase in those patients who experience weaning-induced pulmonary edema. Passive leg raising. Passive leg raising has been found to be a quite substantial tool in fluid responsiveness in ICU, and it is routinely used to diagnose to determine fluid responsiveness. So this trial evaluated the use of passive leg raising to adequately diagnose weaning-induced cardiac dysfunction, and they found that if passive leg raising did not increase the cardiac index by more than 10%, that is Pilow's independence before the SVT, the occurrence of spontaneous vein failure related to cardiac dysfunction was predicted with a sensitivity of 97% and a specificity of again 80%. So what they did was the 30 patients were given SVT trial. A total of 57 spontaneous breathing trials were performed. In all the patients who succeeded SVTs, the PLR was responsive. It means that on giving the patient a passive leg raising, the cardiac output increased by more than 10% and they were preload dependent. But the patients who failed spontaneous breathing trial and those patients who were attributed to having cardiac dysfunction, that is those who has a pulmonary artery equation pressure of more than 18, they found that of the 31 patients, 30 patients were preload independent. Means that on giving the patient a passive leg raising test, there was no significant improvement in cardiac output. And hence, PLR, you can say, can substantially diagnose weaning-induced pulmonary edema. A negative PLR patient has a high chance of developing weaning-induced pulmonary dysfunction, cardiac dysfunction. So how do you prevent and how do you manage it? Because weaning-induced pulmonary edema is basically the sequestration, it's a hydrostatic pulmonary edema. So the role of diuretics is quite profound. Diuretics overall will lead to reduction of the global volume overload. They're quite beneficial if the patient already has increasing LV endoscopic volume. In the patients with non-dilated left ventricle, a larger decrease in LV EDV cannot result in significant decrease in LV EDP because the LV destiny function, as you know, is already a curvilinear curve. So if the patient is on the right side, giving the patient too much diuretics might not decrease the LV endoscopic pressures. What happens in COPD patients is these patients sometimes usually have enlarged right ventricle because of the increased pulmonary pressures and a smaller LV endoscopic volume. So giving the patient diuretics will decrease the LV endoscopic pressure by the reduction of RV endoscopic volume and also by the degree of biventricular interdependence. But how to give the patient diuretics? Is there a guide to giving the diuretics? Yes, a school has used BNP guided approach to use diuretics. And this study by McConsort DSAP, they found that in the BNP guided group, on days when the BNP levels were more than 200, restriction of fluid and diuretic administration was undertaken and was constant for more than 24 hours. And you can see that this group had favorable extubation and the time to extubation was earlier as compared to groups where diuretics were not used guided by BNP. So what they concluded was that a BNP-driven fluid management strategy decreases the duration of weaning without increasing any adverse events, particularly in the patients who have an underlying LV systolic dysfunction. But should we use diuretics to wean all the difficult to wean patients? We have to be careful because unjustified use of diuretics can cause dehydration, hypovolemia, metabolic alkalosis, and also there's the risk of macroatelectasis related to bronchial obstruction by the dry bronchial secretions. So diuretics have the mainstay to treat difficult to wean patients predisposed to weaning-induced pulmonary edema, but use diuretics with caution and guide them with BNP levels. A word about nitrates. Yes, nitrates, how do they act is that basically they cause venodilatation, which can reduce the central bed volume. They can also cause, arterial vasodilatation, which helps by reduction in LV afterload. Also, they cause coronary vasodilatation, which leads to improved oxygen delivery to the myocardium. And this study where they used nitroglycerin to wean difficult to wean COPD patients found that when nitrates are administered at the beginning of SVT, neither pulmonary arterial pressure nor the systolic blood pressure increased during SVT, and hence most of the patients were successfully extubated. So whenever you experience, whenever you're trying to wean COPD patients and you find them hypertensive, use nitrates to wean these patients because it will prevent these patients from developing weaning-induced pulmonary edema. Just this showed that when nitrates were used, there was a quite significant reduction in the systolic blood pressure at the start and at the end of spontaneous weaning trial. And also there was marked reduction in the pulmonary artery equation pressure at the start and the end of weaning. So the mainstay of therapy is diuretics and nitrates. Coming to some certain other drugs which can be used to treat weaning-induced pulmonary dysfunction, is quite often we are quite very fond of using levosimendan. Levosimendan is a calcium sensitizer and also acts on the potassium channels. It is predominantly a inodilator. So it has both the inotropic as well as vasodilator properties. And it has been found in studies done by majorly by Aayush Chawla that there was quite significant reduction in pulmonary artery pressure pressure, increase in SPT when compared with dobutamine. So instead of dobutamine, prefer using levosimendan. Also, they found that a lower increase occurred in the rate pressure product during SPT, suggesting the beneficial effects on the increase in mitral oxygen demand during weaning. Levosimendan was also found to improve LV diastolic dysfunction. And remember that the main cause of weaning failure is the diastolic dysfunction, not the systolic dysfunction. So what happens is that when you use levosimendan, there's quite significant reduction in myocardial oxygen demand because it is independent of the beta-1 receptors, as compared to dobutamine, which acts on the beta-1 receptors also. Also, they found that levosimendan can cause pulmonary vasodilation and further decrease the RV afterload. So by decreasing the RV afterload and by decreasing the degree of diuretical interdependence, it can also reduce the LV filling pressures. Dobutamine, again, as was discussed in the previous slide, dobutamine can cause catecholamine surge, which can further worsen the condition of the patients and may lead to increased afterload also at times. Also, it was found that dobutamine will further increase the myocardial oxygen demand by increasing the rate pressure product. The heart rate increases because of the beta-1 action, and they can be increasing the rate pressure product, causing increase in the myocardial oxygen demand. And because dobutamine is predominantly a method to increase the systolic dysfunction, and we know that the main cause for weaning-induced pulmonary edema is the diastolic failure, so use dobutamine with quite caution and prefer using levosimendan instead of dobutamine. Inoximone was used particularly in it seems to be a good therapeutic option in the cardiac surgery patients who fail to wean because of pulmonary edema, but there is very insufficient data to support the routine use of inoximone. Inoximone by agent is a phosphodiesterase inhibitor, and again, like levosimendan, it has predominant inodilator action. Other pharmacotherapies which have been used in the treatment of weaning failure because of cardiac dysfunction are sildenafil, which is a phosphodiesterase 5 inhibitor. Dopamine has been used, but remember that dopamine has been known to increase the risk of arrhythmias and atrial fibrillation in ICU patients, so use with caution. Acetazolamide have been tried particularly when the patient has experienced a lot of metabolic alkalosis because of diuretics. Beta blockers can be tried in patients who have obstructive cardiomyopathy, and clonidine also has been used because it decreases the sympathetic activity. So whenever you diagnose the patient as having weaning failure from cardiac origin, try to determine the etiology and start appropriate treatment. If you find the patient having low ejection fractions and systolic dysfunction as demonstrated by echocardiography, consider fluid removal guided by BNP levels. You may use inotropic agents like levosimendan and dobutamine. Diastolic dysfunction, if diagnosed with the help of increased E by A ratio or increased E by A prime ratio, you can try fluid removal guided by BNP levels. Treat the underlying cause like hypertension and tachycardia, which can lead to diastolic dysfunction, and also treat concomitant myocardial ischemia. If the patient has an underlying coronary disease, try vasodilators, that is nitrates, try antiplatelets, and if no improvement occurs, you may also consider coronary reperfusion. In COPD patients who experience hypertension during SVT, consider nitrates. And in patients who have been diagnosed with hypertrophic cardiomyopathy, use beta blockers and calcium channel blockers during weaning. So just another approach which can be used to wean this patient is a PLR coupled with echocardiography to wean this patient. Whenever the patient fulfills the criteria for a spontaneous weaning trial, perform a passive leg raising. If you find the patient as having increase in cardiac output on giving the patient PLR, so these are the patients who are payload dependent. So these payload dependent patients are then subjected to a SVT. If at the end of SVT, the echo shows elevated LV pressures, then these patients are more likely to fail the weaning and they should not be extubated. And if these patients are found to have increased LV pressures, then again try fluid restriction, diuretics, and nitrates during the subsequent SVTs. Similarly, if on the onset, if after the patient has been found to be ready for SVT, the PLR was negative, that is, there was no increase in the cardiac index on giving the patient a passive raising, then these patients should be tried first with diuretics and nitrates, and then again subjected to PLR till they become payload dependent. Ventilator modalities is after unsuccessful weaning of cardiac origin, reinstitution of controlled mandatory mechanical ventilation is mandatory. Some of the studies have found that progressive decrements of pressure support levels with 5 to 8 centimeter of H2O of PEEP have been useful. There is a lesser increase in LV afterload than spontaneous breathing patients when the patients have been weaned with pressure support levels. And after extubation, you can try the patient to wean the patients on a non-invasive ventilator, that is on a BiPAP or an NIV. To wean the patients who have a degree of LV dysfunction or who have a concomitant COPD, we will prefer to wean the patients on a pressure support ventilation as compared to the TP trial when they're given SVT. And this is the meta-analysis which showed that giving the patient pressure support will lead to lesser work-out breathing and lesser pressure time product as compared to giving the patient just a TP trial. And also subsequently, these are the subset of patients who should be weaned on an NIV as compared to just extubating them and putting the patients on a normal venturi mask. So the future resides with basically the use of ultrasonography, which can be used to diagnose, which can be used to quantify the amount of pulmonary fluid, which can also be used to probably judge the LV filling pressures. Certain other biomarkers, like instead of using the BNPs and pro-BNPs, some studies have used endothelin 1s, pro-adenomedullin, and troponins and copeptins. So this is the future. Further studies are still warranted to diagnose them and use them appropriately in the subsequent in the patients of vein-induced pulmonary edema. Thank you.
Thank you, Aayush, for a wonderful talk and something which is relatively ignored. Weaning patients who have got cardiac dysfunction, and generally what happens is in cardiac ICUs, people are stressing more and more on not weaning from the cardiac drugs rather than weaning from mechanical ventilation. So you have given a new perspective about the use of the agents like inodilators to help you in weaning patients. So that's a completely new perspective. So we have got some new lots of questions which I have. Aayush, can you unshare your slides?
Yes.
The first question is from Dr. Maninder Thaliwala, and it is directed towards Dr. Ripenmeet. Dr. Ripenmeet, he wants to know what method do you regularly use for bedside for deciding optimal PEEP?
There is no single method which can be tried. It is a trial and error method. We can obviously use the PEEP FiO2 table if we don't have anything or we are not expert in anything else. Other simple method is to check for the severity of ARDS and set PEEP accordingly, or we can use the decremental or incremental PEEP trial based on the best compliance. Recently, we have also started using the RI ratio, and we have found this very helpful in deciding what is the optimal PEEP for the patient. We also look for the lung morphology before deciding on our PEEP. If the patient has a non-focal morphology, then we obviously go for higher PEEP. We try higher PEEP at least.
There's another question to you, which has been sent by Dr. Muthukumar Tajagopalan. And he says, how do you calculate driving pressure in PC mode and PC volume guarantee mode, PCVG mode?
The method which I explained, that is to give inspiratory pause and expiratory pause, can be tried in any patient who is breathing spontaneously, who is on assisted mechanical ventilation. So it is better you shift the patient to pressure support mode from pressure control mode for a while and try these maneuvers of inspiratory hold, and which will help to give you the true plateau pressure and driving pressure. For a while you can, or either you can also try doing this maneuver on pressure control mode also.
Thank you. There's one question now directed towards Dr. Aayush. Dr. Aayush, Dr. Muthukumar Tajagopalan wants to know whether lung USG showing curly B lines can be used to give diuretics to patients.
Yes. You can use lung ultrasound if you can score them, the B lines, and they can be used to give diuretic to the patient. But prior to the development of B lines, it is very important to determine that whether the weaning failure is of cardiac origin or not. Just the development of B lines is not only the sole marker to diagnose as cardiac dysfunction. You have to use diuretics in this patient appropriate in a very careful way. And yes, lung ultrasound with B lines can be used to give diuretics to these patients, no doubt.
Thank you very much. There are no more questions, so let me summarize the entire proceedings for the day. And we had a very interesting talk with all the latest advances in the field of ARDS management, especially lung protective ventilation, which is the most important thing in ARDS. Protecting the lung is more important than, in case you want to wean your patient off, you have to protect, keep the lung protected and ensure that you do not damage it more with your, badly managed mechanical ventilation. So Dr. Ripen has given a very comprehensive view on that, talking about the latest advances, about how we actually, the concepts have changed. It is not just proning the patient, it's mainly about how well you are able to recruit the lungs and how you are able to ensure that high pressures do not damage the lungs anymore. He has, presented it in a very nice and a very clear manner. And this was followed by a talk by Dr. Aayush. And Dr. Aayush talked about how a patient with cardiac dysfunction, how difficult it is to wean a patient with cardiac dysfunction because of the interplay between the cardiac function and the respiratory functions. You have to, sort of balance both of them and ensure that a patient, your lungs, it is not just the lungs which have to be weaned off the ventilator, it is also the heart, which is, actually managing the flow into the lungs, managing the fluid which is going into the lung, and how it functions, how we're able to get rid of the problems of increasing pulmonary artery pressures, and how we can manage it with the use of inodilators. So he's given a very comprehensive view on that, and it's a very interesting topic. I think needs a lot of both these topics actually need a lot of research and a lot of clinical experience to manage such patients. Of course, the both difficult patients to manage, ARDS as well as patients with cardiac dysfunction for weaning. So they are difficult patients to manage, and they have given a very comprehensive view on how to manage both of them. Thank you very much, Ripenmeet, and thank you very much, Aayush, for making wonderful presentations and explaining it all for the benefit of the listeners. Thank you very much. So with this, we come to the end of the academic part of this webinar. And on behalf of Amrita Institute of Medical Sciences, let me thank Indian College of Anesthesiologists for giving us an opportunity to present various new aspects of mechanical ventilation today. Thank you very much. Over to you, Dr. Radhakrishnan, sir.